Getting started now, please. Please come back into the room if you're outside. And we're going to get underway with this afternoon's plenary sessions, of which we have two. And we will be talking about Access Now and the New Frontier. And we will also be talking about patient-oriented research, moving from drags to brags, impact of patient engagement in primary healthcare research. Before I introduce the topic this afternoon, though, you will have noticed in your program that Dr. Philpott's talk was entitled Martin Bass Lecture, Attachment for All, Building a System in Canadian Primary Care. I was so enthusiastic about telling you about a new primary care quality improvement research opportunity and introducing Dr. Philpott, I did not get a chance to talk about Dr. Martin Bass. And I want to do that very, very briefly because this is incredibly important. This lecture has been named after Dr. Bass for many, many years now. He was the chair of graduate studies in the program in the Department of Family Medicine at Western University from 1977 to 1980. He was the first director of the Center for Studies in Family Medicine from 1986 to 1996. I'm sure this is the first Center for Studies in Family Medicine in Canada, if not the world. His career as a family physician researcher had a major impact on the development of family practice research around the world. The lecture honors Dr. Bass and a strong commitment to family medicine research. And my brief anecdote was that in the early 1990s, when I was a very junior, very brand new researcher, Martin and colleagues who were primary care leaders in research at the time were producing a series of books on primary care research. They're having a conference for each book, and they invited me as a brand new person to introduce a topic and to contribute to a book chapter. Now, you know what it's like as a brand new, newly minted researcher to be asked to participate in a book chapter that you're going to be an author of. It was the most generous, most amazing, wonderful gift that I could have had at that stage in my career, and epitomized Martin and his approach to everyone and to me and to everyone else. Now, on the topic of Western, it's also my great pleasure to introduce Dr. Scott McKay. He is the chair and department head of family medicine at Western University. In my day, it was called the University of Western Ontario. Department head of family medicine at London Health Sciences Centre and also at St. Joseph's Healthcare London. And he is going to be the moderator for the session, which he will now introduce.
Thank you, Rick. Welcome everyone to what I think is going to be just a wonderful end to our day, this and the next plenary sessions. So as Rick mentioned, I'm Scott McKay, the family doctor in London and the chair of the department at Western. We're going to start off by just asking each of the panelists to introduce themselves and maybe give me just one or two sentences of why primary care access matters to them, and then the format's going to be I'm going to set up a few things about access, some thoughts, some measures that have been used, maybe things that we haven't considered yet, and then each of the panelists is going to have an opportunity to talk with us for about 8 to 10 minutes, and then that should leave plenty of time at the end to get a great, robust discussion and conversation going. So actually we'll start at the far end with Kayla.
I'm Kayla Menkhorst. I am the Executive Director at Eganville District Seniors, which is a home support agency as well as a Seniors Active Living Center in Renfrew County. I was also the patient advisor for a research project with VTAC in Renfrew County. And I'm also here as a patient, as well as a caregiver, and representing those in my community, as well as the voices of patients across the province and across Canada. And the reason that access is important to me is because there are so many barriers, and so many people are slipping through the cracks and not understanding how to navigate or how to access that care. And to be able to be part of that and be able to be part of a long-term solution, as well as an immediate solution, is why I'm here today.
Thank you. Mylaine?
Hi, my name is Mylaine Breton. I'm a professor at University of Sherbrooke, and I hold a Canadian Research Chair in Clinical Governance and Primary Care. Access is really important for me, and I did all my research project program based on that. I'm looking for two components that we talk today: unattached patient and timely access.
Hi, I'm Liz Muggah. I'm first a family doctor, and I also work now in government at Ontario Health, and I'm the clinical lead for primary and community-based care at Ontario Health. And I care about access for the reason that actually my job literally depends on it. If I do this badly, it's not good for my patients. I also can get fired because at Ontario Health, my job is about measuring and being accountable for timely access to care, attachment to care, through the work I do at Ontario Health. And then in addition, I have been seconded to work with Jane Philpott on the PCAT table, and you heard her speak about the commitment that we have directly to the Premier and the people of Ontario to get that right.
Thank you, and welcome to our panelists. So we heard a lot this morning from Jane, about attachment, and I think, it was something else that came up there. I think this is the next hour. Is going to be a great chance for us to kind of muck around and talk about, what is access and how do we measure it, and what is it going to mean for patients to have good access. I was thinking about it a bit, and attachment and access, I think are, so these are some process measures on the journey towards, I think what our outcome measures really are around the quintuple aim. And once we get patients attached, then we're going to get them access, and then hopefully, that's when we start to see, the benefits to patients, to systems, to providers. If we think about how access has been measured traditionally, you can still look up on the HQO website, they talk about same-day, next-day access, same-day response to a phone call, in-person visit 7 days after a hospitalization. I remember many years back now implementing advanced access at our clinic, and it was the third next available appointment was the important measure that we had. I'm not sure if that's changing, and what's different, and I think that's one of the things we're going to talk about this afternoon. We have to think about some of the collection differences on these measures. A lot of patient-reported measures around access, but there's also health administrative data. And what's the balance? How does that figure into knowing, are patients, getting the access that they need? It's getting complicated. We heard about, it's the age of on-demand, and we heard the word convenience around healthcare access this morning. And so there's, lots of things happening. Public and private efforts outside of, primary care teams are providing access, whether it's walk-in clinics, virtual care at the grocery store, pharmacists, executive medical clinics where actually you can pay to have someone help you navigate and access the system. I can go on my phone, the commercials tell me I have all kinds of problems as a middle-aged man that I can get the answers to discreetly in my own home. So access is everywhere, but how does that all fit together? And some of the questions I hope we'll get to today are around, what is access? Is it access to a team member? Is it to the pharmacist, to the RN, to the NP? Is it an MD? Is it actually the MD that you're attached to, or is it another MD in your group? Obviously, since the pandemic, there's been a big shift to virtual care. How does virtual care figure into how we measure access? We heard this morning from Dr. Fitzsimon about VTAC and IVC. These are great initiatives to increase access, but it hasn't really traditionally been in how we've been looking at that. And something we actually haven't heard much about today that seems to be in every healthcare conversation is AI. And how does AI actually fit into access? And, logging on to your team's website and having a chat with the AI bot to help you sort out your problem, is that access? So there's lots and lots of things to consider when we're talking about this. And so hopefully we'll get today touch on some of these things, the perspectives of what access means to different people, different groups. What are some of the best practices around measuring access? Where are the gaps? And where do unattached patients actually fit? We're talking about attaching patients, but there's still going to be unattached patients, and what's their access? And then particularly the question, what does timely access to primary care mean, depending on who you are? So anyway, I've probably said too much already. I really want to get the panel and their expertise to weigh in, so I'm going to hand it over to Kayla to start us off.
I'm going to put the water here before it's spilled. Thank you very much for having me. I'm honestly honored to be invited here today to speak and have a voice on behalf of the patients. But I also want to make it very clear that my experiences are very different than someone else's experiences. The people that I talk to on a daily basis are experiencing different things than other people are experiencing in other areas of the province. So this is my perspective. This is the things that I have learned from different projects that I've been part of. These are things that I learn on a daily basis when we have seniors giving us a call to ask us what they're supposed to do because they don't have a primary care and they don't know what they're supposed to do next. But their chest hurts or something feels off. What do I do? So I'm here today to talk about those experiences and those perspectives from the patients that I deal with on a daily basis, but also from my own learned experiences from being a caregiver for my grandparents and for my mother-in-law as she fell ill, and also as being a patient who was diagnosed with a disease that we weren't sure what the next steps were going to be. So that is why I'm here today. So please don't take anything what I'm saying as that this is the whole holistic picture. Access is not a cookie-cutter approach. What's going to work for me and gives me full access to healthcare is very different than what it's going to be for someone else. So as we're coming up with all these solutions and all these plans and all these long-term goals, it's really important to remember that for patients, it's about options. Patients, some things, for example, virtual care works great for me because I have high-speed internet where I live. I know how to utilize the different resources that we need to connect for virtual care, but that may create a barrier for someone else because they don't have high-speed internet, or they don't know how to do that. They don't have a computer. So when we're coming up with these plans, we really need to look at the different hybrid situations, options. When I was diagnosed with cancer in 2020, my choices were taken away from me. I had no choice other than to do what the doctor told me to do so that I could live through it. And at the time, I was fine with that. Just tell me what to do. I'll go there. I'll do all the things. But looking back at my experience, I wish that all those choices weren't taken away. I wish that I was able to look at my healthcare and say, okay, I can do this or I can do this, and here's the pros and here's the cons. I can, did I have to drive 2.5 hours to get to the hospital in order to have treatment? Maybe there was other options that were closer to home. Do I wish I could have received all the care in the community that I reside in? Yes. But I also understand that I'm privileged. I am able to get into my vehicle, and I am able to drive to my primary care because I have one. Again, a privilege. I'm able to drive there, and I'm able to have an appointment on a time that's suited for me. I'm able to take the time off of work to be able to do that without worrying how I'm going to pay the bills. And I have a support system in place that's going to pick up my kids after school if I'm not able to. And unfortunately, that's a privilege. Everyone should be able to access the care how they want to, when they want to, and convenience is really important in that. Being able to pick up the phone and call primary care because you're attached to someone, and being able to talk to someone and be able to book an appointment in a time that's suitable for you, where you don't have to take off work or call in sick, where you can book an evening appointment, where you can have it at a time in a timely manner, where that you're going to get the care that you deserve. That's what's important for patients. Immediacy is also really important. So the things that I'm hearing today, and this is not, I'm not a researcher, I'm not in primary care. I work in the healthcare field, but I'm not primary care. And to hear these things and these steps that are going on to make the healthcare access better is so relieving. But patients don't see that. If I have a person who contacts me and says, my father is 80 years old, he has a primary care, he has a doctor, it's a 2-hour drive away, and the appointments are taking 3 to 6 weeks to even get in, what do I do? Well, the solution in 6 months from now to have them have someone closer, or whatever that solution may be that we're all building together to take away those barriers for patients are really important. From the patient side of things, the question is, what do I do now? I need a solution now. So as we're building these solutions, and it's so promising to see all the things, to hear Jane mention about how many people are getting taken off that waiting list on a weekly basis is amazing. But when I'm a patient, I just care, like right now, what do I do? I haven't been called yet to be taken off that waiting list. So what are the options now? So I think that when we're looking at these solutions, those longer term solutions, or a week from now, are great. But we also have to keep in mind that the patients are looking for what they can do now. That immediacy, when you're diagnosed with something, waiting for, 6 weeks to be able to go and see an oncologist is not what patients are looking for. They're on that forefront. Their mind is filled with all the things they have to do to get better. And so those interim gaps and building the bridges to be able to build and bring all of that together so that the long-term solution will work, but it will also have something for the patient now is really important. And that's going to build the trust that the patients have in the healthcare system. It's going to build trust that they have access to primary care when they need it, when they want it, and how they want it. And those are all big steps and lofty goals, right? And when we're talking about not having a full cookie cutter approach, that's really hard to say, okay, well, that might work great, but it's not going to work great for everyone. So like, Kayla, you literally just told me two opposite things. What do you want me to do here? The thing is having those choices and having those options. So, when we talk about virtual care, from a rural perspective, the town of Eganville that I reside and work in is 1,300 people. Our closest hospitals are at least a 30-minute drive if you live within Eganville, okay, which is in Renfrew County. So having options, and Jonathan discussed about VTAC, having those options where there's hybrid, where there's in-person. One of the things that we found in that research was that for the seniors, it worked really well to be able to go to a primary care facility and have that video conference, because they weren't able to go and drive the 2 hours to the specialist, but they also didn't have to worry about whether they could connect to the internet or not. So by looking at those and virtual care and saying, well, this is a solution, it's not going to be a solution for all. So keeping that mind open to look at what the patient and what that priority is for the patient is for them to choose the way that they're receiving that health care. The other conversation that I've heard lots around the table and in the discussions is about the team-based approach. Love the team-based approach, right? When you're a patient, you want to feel trust in the system. You want to feel trust that your primary care provider is having the whole picture. You want to be able to sit down with your primary care provider, and they're going to know about the fact that you went to this specialist or that you went to the dietitian for this, and have that conversation with you. So by having a teams approach, we're breaking down those silos, and we're having that communication. But there needs to be a pilot at the front of that. So if you're looking at community health teams or community health centers, family health teams, there still needs to be that one person that even after a doctor's appointment, that the patient can call up and say, so I was talking with Dr. Smith, and Dr. Smith mentioned I was supposed to go see someone about like my leg or something. That person should be able to help direct, and that person should be able to have those answers. And those team-based approaches where you have someone that is focused on the patient and you have someone who can see all the information is going to help the patient navigate that. That's going to help give them the access. And by no means in the team-based approach am I saying that primary care should know every single thing about every single ailment and every single support system in the community. But it's about aligning yourself with the partners that can provide those answers. So if you have a client that lives a patient that lives 30 minutes away and transportation is a struggle, a partner would be one of your community support agencies to say, okay, well, you can contact these guys, or I'll send a referral to this group who does community transportation. And just knowing about what partners you need to align yourselves with that will help out your patient in their community will really help guide that person, and which will help give them the access that they need to healthcare. One of the things that are asked is about healthcare in the future. And this may be from working with older adults especially, but if we looked at about how healthcare was years ago, every small town had a doctor. And that doctor you could go into, and they knew your family history, they knew about every ailment that you've ever had. They also know what you buy at the grocery store, because it's a small town, and I'm speaking rural. But that was that connection that you had with your primary care. It was an ally. It was someone that you could go to when you had a question or a worry. Well, now patients are feeling that they're in this reaction. I have a problem, but I'm not connected to primary care, or I'm not sitting in an emergency room for 8 hours, or I can't get into my family doctor. Nobody cares. It's fine. And then all of a sudden it's an emergency, and things that could have been treated long before and prevented are all of a sudden an emergency situation. And patients don't want that. Patients want to go back to the way it was. They want to have connections with their primary care. They want to have connections in their community. And again, not realistic that a hospital is going to be built, and I keep using Eganville as an excuse, or as an example, sorry. A hospital is going to be built, and there's going to be a PET scan, and an MRI, and a CT scan. That's not the expectations of a patient. The expectations is that they're going to have one person that they can go to that's going to connect them to the different sources that they need. That's going to be that pilot in their healthcare journey. And that's going to be the person that's going to help them and stand beside them instead of being left alone to figure out whatever it is that they're supposed to do next. What matters to patients is that they feel that the primary care cares. And they can't feel that if they don't have access to primary care. They're okay with seeing 4 different people, as long as those 4 different people know about what that other person said. And that's the access and the care that the patients are looking for in healthcare today and into the future. So I just want to end this spiel with the fact that I am so, and I've mentioned this before, but just I'm enlightened by all these things that are happening. And the fact that, I was invited here today to speak, the fact that patients' voices are being heard and being taken into consideration in these long-term plans and the short-term plans, right? When we're looking at how many patients were now connected with primary care from last week to this week, that's immediate. But the fact that the voices are being asked is a huge step in the right direction for true patient care and access to the primary care in the community the way that they want it, the way that they need it, and the way that they hope that it's going to be. So thank you.
So hi everyone. Oops. Okay, so what does it mean, access? Access is at the heart of the premise of public system. It means not only being able to see a provider, but also benefit continuity of care, equitable follow-up, regardless of where you live or what is your status. So I'm going to talk about access, and as you know, it's an important value for everyone, particularly for citizens across province, as Orchid said, in different provinces. So accessibility, it's an important value, and as we said today, it's really the foundation of where we want to build a universal system. So despite this system, we do observe challenge and variation and inequity among those 2 elements. So I want to discuss and present some idea, solution related to those 2 challenges with the Quebec perspective. So the first one, it's really related to barrier and navigation for unattached patients. As you're aware, often the key to entering primary care is having a family physician or nurse provider. So in our system, if you do not have this key, it's the first challenge you expect. And even if you have this key, if you are attached to a family physician, it's really challenging sometimes to have timely access. So I'm going to present briefly, because I have only 8 minutes to present, some solution according to those 2 problems. So the first one is centralized waiting list. So it's something that a lot of provinces have put in place. As you were in Ontario, Healthcare Connect. So the design vary among, they have some provinces who design the centralized waiting list based on categorization, such as Ontario with Healthcare Connect and Quebec, or first come, first serve as in Manitoba. And Canada is having a unique situation because we are almost the only country in the world that puts centralized waiting lists for an attached patient. But this is not an innovation, but this design, it's growing in other country. Portugal, France are looking also to put that kind of model because they are looking, they have an increased number of unattached also, that is not only Quebec. In Quebec, that was really popular, and at some point it worked. we implement guichet d'accès aux patients, clientèle orpheline, and the result means to help to attach 1.5 million over the year through decentralized waiting list with a provider. So it's work, but the delay remains really high, with an average of 600 days to be attached. And we observe significant variation among regions. And I feel that we may share this with Ontario, but congratulations for the 50% decrease of the waiting list. Us is still continue to grow up. And because you can wait a long time to be attached to the centralized waiting list, so we add something, an innovation. I don't recommend to do that, but we implement GAP, Guichet d'Accès Première Ligne, and the idea is really to try to give services for unattached patients instead of going to the emergency department. So the idea was based on the hypothesis that the majority of the consultation don't need to see a physician. That was the hypothesis. And we conduct a survey in one region, and that was true. 50% of the requests went orient to a family physician, and only 5% of the patients who call into the GAP have been to the emergency department. So that did what it's supposed to say. But also, when in the survey, when we ask the patient, does this service respond to your need, we have high level of unmet need if they see not a family physician or a nurse. So there's something that you have to keep in mind. So this gap responds to what's supposed to be. That is not continuity. That is only access. So now I want to talk about the second issue that we talk about. It's timely access. They have something that have been implemented around the world that is well known, and it's have been implemented in Canada. It's advanced access model. So we revisit this model recently because now it's more based on an interprofessional team, and it's really roots on continuity of care, knowing your patient. So I'm going to present you that we developed a few tools in Quebec to really help family practice and to improve the implementation of advanced access. So we developed two really to support them in the implementation, because we say that is the model to improve timely access. So we developed a tool that we call Aura. It's a self-assessment survey for physician and nurse practitioner, and that give at the end of the survey a real strategy to improve, and it had reached more than 1,000 family physicians in Quebec who use this survey so far. We also have a patient survey on access, and I'm not good at 120,000 patients who respond to this survey so far. So Statistics Canada called us to ask us how we reach so many patients. And today I really want to take the few minutes I have that we also, the third tool we had is really, we developed data that is fueled by EMR. This morning, someone asked how we can leverage that. So we're really proud about using the data to support the practice of physician. And just take a note that Primary Care Access Improvement Program launched this summer by Health Excellence Canada, in which 8 clinics have been selected in Ontario, is based on the tool we developed on advanced access in Quebec, as well as Jennifer Reynolds, their work in Ontario. So we're really proud that this is a key to support the practice to improve timely access. So if you have been selected, congratulations, and they may have a second cohort soon. So as you know, primary care component, the development of primary care dashboard is really, really important to support the improvement, and not a way to be coercive, but really to support. So the goal is to turn data as a lever for collective reflection. As Edward Deming said, without data, we are just another person with an opinion. Clinics are eager to access to their data to improve. To date, we have recruited 100 family physicians to participate to our dashboard. I will say that it's not because in Quebec they are so willing to participate to a research project, but they want their data. Professionals want to improve, and data is the starting point. And I said everybody were kind of agree about this statement this morning. So we develop all the conceptualization of the indicator that fuel our dashboard is based on a research project that we did, a literature review. We did a consultation with experts, including patients, and we did extract manually in EMR to be able to present those indicators. So if you are interested, you have an article on that. So at the end, we select 8 indicators that we're able to extract, and we develop, you will be jealous, automatic extraction technology compatible with 3 different EMR to fuel our dashboard. And each family physician who participate to this receive their personal report over the last year that compared to their colleague in their clinic. We don't name the name of the clinic, but you see their own data. And something that is really important is this data are confidential and not shared with the authority. Our philosophy is focused on reflective practice and feedback as a lever for improvement. And we maintain a real-time dashboard that is fueled every week on those 100 clinics. So here's an example of a physician, a report that we shared to a physician. So, and it's regarding the demand and supply. The question is the provider are balanced? I think we have a lot of questions. Do they can take more patients? We don't talk about that in Quebec. We don't say, oh, if you're good balance, you will take new patients. But at the end, if they are balanced and have place, they could decide to attach more patients. But the idea is to look what is the availability of the patient, what are the characteristics of those patients, and based on that, we do a roughly estimation. We calculate 1 consultation per year for LT patient. We calculate 2 consultations for a baby and below 5, and an estimation of 3 consultations from having a chronic disease. And then we look how many consultations did you have with your patient last year, how many with the patient in the clinic, because it's okay to see the patient of your colleague if they are not there, but are you enough available for your patient? And it's a really interesting exercise. And when we look for the 100 clinic, it's roughly 25% of the physicians that are unbalanced. But it's 75% that are balanced. So at some point, it's really something really interesting to see if I'm offering enough availability for my own patient. We value relational continuity. And I'm going to show you an example of 10 clinics, let's say, and we compare. And here is the third available appointment. And as you can see, they have a huge variation inside a clinic and among clinic. And also, on third available appointment, we should have target 2 or 3 days, let's say. But as you can see, we have a median of 15 days. So there are strong potential for improvement. And here it's related to relational continuity. So it's the proportion of the visit with their own physician compared to the other physician of the clinic. And again, there are huge variation within and across clinic. Ideally, the target should be 80%. And in teaching clinic, it's more related to 70%. But all those data are really interesting to fuel and to be inspired to improve. And finally, something that we're really proud of is our indicator on collaboration. It's something that we don't really have data, but it's how many visits your patients see the other provider. It depends on the other provider inside the clinic, but if we say that the future is primary care team, that is an indicator that we should track and improve. So hopefully I put the stage for the panel discussion about those ideas and inspiration. And just because I have the micro, this morning I'm really, really jealous of all what you invest in primary care in Ontario today.
So I'm going to sit here because you may not know from that side, but actually if you're standing at the podium, it's very hard to see your slides. And this way I can kind of get the run of the crowd. And I thought I might just start by thanking Inspire and Rick and Elliot and the whole team. Right? I was just with Rick before I got up here, and we were looking at all of the presentations and the posters, and every single one of them, I can tell you now in my role as working in government, was of interest to me. So just like congratulations to all of you and the research you're doing. Please keep doing it. My call to you as a research community is to hold us accountable, those of us in government, to stick with the evidence and what we know from other jurisdictions across Canada and beyond, but also certainly in Ontario about what works. Please be where the puck should be going so that we can see the direction we should be headed in. So this is such a great gathering of minds, and wanted to start with that. That's the good news. The bad news is if we talk about access, we are failing, frankly, in Canada. Access in primary care has really been our Achilles heel for a very long time. The last data we have, of course, is data that really comes from still emergence of the pandemic, where our numbers were really low. It was about a quarter of the population who said they could get same-day or next-day access when sick. That was down from about 40%. I mean, it's really grim. So, I mean, the flip side of that is we can only get better. And my talk is not going to be so much about the solutions, although that I think will follow in the discussion. And Mylaine talked about some of those, and Kayla talked about some of the solutions. I will give you a few teasers, though, in terms of numbers that I think are interesting if we want to go to these places. So we, for sort of new ways of looking at access, in Ontario, we have this system called Health 811. If you've never heard of it, please go search it online. Not everybody has heard about it. It's available 24/7. We had 500,000 people use Health 811 last year, make a contact. We had about 110,000 who used the chat system. And then we had about 60,000 who used an AI robot for symptom checking. So that's kind of interesting. We have virtual care clinics. So Jonathan talked about the one in Renfrew. We also have that covering the whole province. There are 6 of them. 3 based out of hospitals and 3 based out of community centers or community-based care organizations, and about 45,000 patients across Ontario last year used that service. So those are sort of centralized virtual care run with NPs. So lots of things that we're testing out at a provincial level. The angle I took here to sort of complement what you've already heard is to look at the measurement of outcomes in primary care and give you a flavor of what we're doing in Ontario. There is no question, and Jane started out her presentation talking about these pillars for the establishment of a real primary care system. There's no question that primary care data infrastructure is required for us to get anywhere far and sustain and continue to improve what we're doing in Ontario. So I'm going to show you where we're at and what we're doing. This is work that is shared across Ontario Health and the ministry, and we're not at the end by any stretch. We're at the beginning of this process, but I think it gives you a sense of kind of what we're trying to create and where there are opportunities to measure. And I actually don't see my slides here, but maybe they come there, really? Oh.
Maybe if you come here, you can see a little bit.
Okay, that was a failed attempt. Can you put it here? Look at that, I thought I was really being smart. Oh yeah, there we go. Okay. I'm going to stand now that I'm standing. Okay, so this is the sort of ecosystem of primary care data measurement in Ontario. It's a micro, meso, macro level of what we're measuring. So, and obviously that's critical. You can do system level measurement. That's really important when you're like the premier and you're trying to see, are people doing what they're supposed to be doing with what I've put out as the sort of mandate. And then all the way down to the micro level, of course, we all know that the system only moves because at a micro level, those of us who are clinicians and practitioners on the ground are really getting our data and doing something with it. So at the micro level, I'll pull out what's called the My Practice Primary Care Report. So this is a provider level and practice level report where you get data fed back to you on a number of indicators. We don't yet have access, but we do have a number of indicators on attachment and other measures of quality. And so this is an initiative that we've got at a micro level. If you are lucky enough to be a community health center, there's a whole lot more data that you get because of what the Alliance has done, and kudos to Jen Rayner and that organization. But this is at the micro level. If you move up one level further at a meso level, we do have a whole performance measurement framework that we've developed to take a look at what is important in primary care, including access. And you saw in what Mylaine showed you that no matter where you were in the province in that RK survey, at the very top of that list in terms of outcomes of importance to patients was accessibility. We have a quality improvement program where practices teams voluntarily report on a number of indicators. And what's interesting is many choose to do patient-reported measures on access. We don't have that data in a way that it could be used for anything other than individual learning of the team. It's not something that's rolled up at the level of the province, but we do have a quality improvement program where some of that data is being collected. And I think interesting that somewhere above 50% of all teams independently in their quality improvement plans have identified patient-reported measures of access as being important ones that they want to keep an eye on. And then at the system level, multiple places where we're measuring different dimensions of primary care quality. So we have an OHT data dashboard, which I'm really excited about. I'm going to show you a little bit about that. So these are our meso-level structures, the OHTs, who are playing a critical role in terms of supporting the attachment of patients, looking now to help with planning around primary care. We have the primary care experience survey. So we used to have something called the healthcare experience survey. And it was at a very system level, looking at how are we performing in the province. That's now been replaced by something called the primary care experience survey, and we do measure patient-reported access there. And then at PCAT, we have some KPIs. So, and those actually came out in that crazy 57-day plan that we did. We came out with a set of indicators that we thought the plan was not crazy. The timing to get it done that quickly was the part that was that was more crazy. But those system-level KPIs, which include things like who is attached, also there is a measure in there for same-day, next-day access when ill. So the next slide is looking at just a couple of examples of, let's see if I can do that. There we go. So this is our data dashboard. This dashboard is, I think, really an amazing advancement for us in terms of primary care planning on many different dimensions, particularly on attachment is where we've started. So it's available to all Ontario health teams. You just need a OneID to get it if you want to get it. I put the email there. If you're affiliated with an OHT, you can get access to this. So there are reports now in here to support planning at the OHT, that geographic level for primary care. And there's a package, we call it the PCAT data package, and it's got a particular set of information that is really critical again for planning. So we don't yet have patient-reported or other types of measures for access, but we do have sociodemographic indicators, we do have attachment, and we talked a little bit this morning about attachment measured in multiple different ways, FSA, CSD, ADA, you may remember all those early acronyms. We have the physician contact list, which I think is really exciting to know who are the doctors, what specialties are they, where are their practices, what language do they speak, and then a number of other things that I've just put there. So this is one effort around, creating the data infrastructure really at I would say at a meso level. This is the My Practice report. So Ontario used to have a lot of reports that we sent to primary care teams and clinicians, and we would send them through, in different ways at different times. And one of the things we heard back from the sector was, could you just please put them all in one report? So we did that, and with a lot of consultation, have worked on a presentation of this that was a little more friendly. This is iterative, so as we move forward in primary care, these are indicators that will change depending on the priorities of the system. And ideally, where this goes is a place where it can integrate not only what it has now, which is more based on health administrative data, but then can link into the actual EMR and give you real-time data on what you're doing in your practice. So there are about 10,000 users who are using this, which is great. So if you are a clinician, we can help you get signed up for this as well. All right, so where are we looking to? So this is like where, I mean, I think where we are now was we had a bunch of disparate ways of measuring primary care outcomes. So a bit of health administrative data, and we go knock on Inspire's door, and and then us at the Ministry in OH would sort of replicate these methods, and then we might have a little bit that came through a quality improvement report and a bit that came from a survey. So what we're looking at now is really saying, look, if we really want to get to where the puck is going, we are going to have to be much more aggressive and detailed at a practice level in what we're collecting. We've been missing out a lot of the activities of certain providers, again, with the exception of the work that's happened over through the Alliance, where they've had very detailed collecting, but the rest of the sector has not been collecting information on what other team members are doing. In some ways, over-collecting, I think, on some operational data and under-collecting on things that would help us better understand quality. So this graph is actually the real graph of how things have gone with the first round of funding that we had, which was called the EOI. So this is the tracking of that, our progress against what the target was is the blue graph, and then the other graph, the blue line, and then the red line is where we actually got to, so we exceeded our targets. And this kind of very detailed level reporting from every single practice about what they're doing in terms of attachment, when, what date, to whom is what we're starting to build. And if we don't do this, I don't think we're going to get more investments in primary care, and we probably will have a hard time tackling some of those big questions that, like Tara put in front of us, which is, our teams attaching more than non-teams, and her big answer was no. So then how do we get better? Well, if we don't have really this accurate data to measure this, it's going to be incredibly difficult for us to get there. So here are a couple things in terms of where we're heading. So as I mentioned, more holistic reporting, making sure we're pulling in NP data, the data of other providers, as I mentioned. Record level data. So one of the things in Ontario Health that we look to as a system that's done extremely well in terms of its reporting is the cancer care system. And the cancer care system has very detailed record level disaggregated reporting on patients. And we've done some work looking at that, and I will say we've engaged primary care associations and other partners to help us kind of take a look at, if we're going to start collecting this record level data, what should we be collecting and how? So we have a standardized way of doing that. This is a burden for teams. I'll just say, no, so I said that's record level data, and the third one is inclusion of provider information and more personal health information about patients, and pulling all of this together. This has been a burden for our teams. So not all teams are doing this, but our new teams who are being awarded parts of this money, this $2.1 billion that has now gone into primary care, are being asked a lot to report in much more detail. But if I kind of show this here, so this is like just calling out, our expansion that we've had in 24, 25, 26, and then this next one, the 26 that will come, 26, 27. We're going to be up to 200 or more of our teams where we will be collecting this very detailed record level information. Certainly as I say, the burden is high now. The idea is, as we continue to develop this, the back end of it will be to automate as much as we can, so it's not that burden. I mean, if you're in a hospital, it doesn't feel like how it feels right now at the front line with what we're asking primary care to do. We know that. So that's the intent. And I'll say, standing here with my OH hat on, we are, and I know with my ministry colleagues, and Jillian and others are here, we are firmly committed to the need to create a proper primary care data system. We are not going to get it right away. It's going to take time. It's going to take some money, but we know we need to get there, and it would be foolish, frankly, to put this kind of investment into the system and then not have a way to track what you're doing. But welcome you as researchers in this journey with us, with your advice on, I think there's a lot that we can continue to learn to help us do this as quickly as we can. And one of the side conversations that I had with Jen Rayner today was a bit about just basic things like what kind of learning collaborative is necessary to support teams to help them in the process of collecting and recording this kind of data in this sort of detail. It's not something that we've been doing in primary care, and I think we just have to be mindful of not only the infrastructure and the digital data infrastructure, but the human people who are involved behind creating this so we have this data. So look forward to the rest of our conversation, and hopefully I'm sure with what the three of us have shared, we'll have some lively questions and discussion.
Thank you. Thank you very much to our panelists for those insightful and informative. I was drinking out of the fire hose, it felt like a little bit with everything that was coming at me, but it was great. Just before we get to audience questions and comments, I'd invite you to start to come up to the microphones. I just want to go back to Kayla for a minute, now that she's heard a research perspective, practitioner and government perspective. Any reflections on what you've heard and things that maybe you liked or you didn't like, or a different direction that we need to be thinking about?
Yeah, the research that's being done, the information that's being collected is giving this broad picture, and it's really nice to see that, and to then see that this is the information that's being collected, and this is what we're going to do with it, and this is how we're going to change and we're going to better access to primary care. That is really enlightening, and you can see that in all these different ways. But what also has stood out to me is the fact that this information is being collected, but it's not being told to everyone, okay, this is the way you're going to do it in your community, right? To have a call for proposals where the communities are reaching out and saying, this is the model that we're going to do because of this information that we collected, that these are the gaps and these are the barriers and these are why patients aren't getting access to primary care, and then the solutions are being found, is the way that we need to look at this. And so thank you to everyone here for collecting that info. Thank you for sharing it. And most importantly, thank you for the work that you do in the healthcare field that is really allowing patients to get there, right, to get that access. What you're doing is really, really important. So thank you.
Thank you.
I'm clapping for everyone, but nobody else
Yeah.
is. Thanks.
I'm going to sit on the edge of my seat here for the rest of this compelling chat. So just so I can see the microphone on this side. And we'll go to Kathy.
Hi, Kathy. Are we on? Oh, there we are on. Kathy Risden, McMaster University. One of the themes that we haven't explored today about perhaps a hidden tax on access is the multitude of interests directing physician-clinician attention towards low-value work. The 27-hour day, I think, is a great metaphor for how much attention is stolen to perhaps serve guidelines generated by specialists, generated by pharma, forms of screening that actually don't help. There's a great article saying that if everyone did a brief intervention recommending physical exercise, there'd be, the equivalent of, was it 1,000 patient visits that we would lose? Not that we don't all think exercise is important, but actually a physician spending 20 minutes advising on that is not potentially as good a use of time as having an appointment available for someone with symptoms or someone who needs care. So feels like there's some of our system that has been eaten up invisibly for things that offer no value, but are shaped perhaps by market forces or a whole variety of things. And a recent BMJ article basically said, let's stop doing so much prevention. Yeah. It's a misfocus of our attention. It's actually really challenging to tell a physician stop doing a thing that promotes what we all believe is immortality if we just prevent it all, right? So. Yeah. Could Health Quality Ontario tell us some things we should stop paying attention to, because seeing sick patients is a lot more important than brief advice on whatever? Anyway, I would love for us to open that space as well.
Can I take a jab at that? I'm sure we all have something to say about that, but let me start, Kathy, by one angle of that. And those who I have chatted with know I talk about this all the time. And I'm really grateful you think that Health Quality Ontario, or former Health Quality Ontario, which is now OH, could solve this, but I'm actually going to put this back on all of you because we need your help with this. We need to define what is the job of primary care and what are our core services, right? Like, we basically do three things. We do prevention, we do chronic disease management, and we see acute illnesses. And the problem is prevention and chronic disease management, especially the sort of these non-acute preventative things, which are important, have taken up the great majority and more of our day, because it's 27 hours a day, which is more than we obviously have. So I think we need to start saying, like, what's in our job and what's not, and then who should do that? And is that a robot? Is that AI that can do that in the background? Is that a nurse practitioner? Is that a family physician? Is that the team? Is that the medical office assistant? And a really important pathway to me is, like, what can the patient do? How do we empower the patient? I don't think we do a good job at that either. So I feel like part of it is, a bit of a choosing wisely, help take things off our plate. And I think part of it is just really getting concrete on what's in our job scope and who should do it. And when we funnel it all to one person, one nurse practitioner, one family doctor, you're just not going to get it done. So the opportunity is, in Ontario, we've just put all this money into teams. So I think actually a number of the presentations downstairs addressed some of these questions that I'm talking about. So that would be my beginning approach. Yeah, yes, I think we do need to talk about that. I would also say this same analysis should happen with decisions that we're making about other parts of the healthcare system, like pharmacists, such a valuable resource. And some people may have pharmacists in their team, but we all have a community pharmacist who is part of our patient medical neighborhood. What is the work that they can be doing? And are they working to top us? Like, what's their core service? Who should be doing that? What's highest value? Is it giving the patient, I don't know, the Benadryl for the allergy, or is it actually looking at all their diabetes meds and optimizing that? Both of those things are in scope for them. So I think that's a question I would ask of, the value of the care, not just in primary care, but beyond too.
The question is really important because when you think about how we can respond and having great capacity, at some point you have to think what we should stop doing, and that is the question, and where we can find capacity. And in Quebec, when you do coaching with the clinic, in that case, you should see the nurse. But when you look at the calendar and the schedule of a nurse, she don't have any availability. She see patient chronic disease that are stable for 10 years. So if you want to change the capacity in the nurse caseload, you have to change the way that she works. So in some clinic now we say, okay, what is the value of seeing a patient that is stable and it's well organized for 10 years? So let's stop doing that. Give some tool to the patient, and if the metric change, they're going to have an appointment with the nurse, and then you're going to create capacity. So I think we have to stop following all the guidelines, because if you're following all the guidelines, you won't have any capacity, because they said that you should see the patient for 10 years. So I think it's having this reflection, and you open totally a new box with the AI, how we can support navigation and have valid information to the patient. Patients want to be engaged, but we have to give them tools. So in clinic, it's really simple. We give a paper, and you say, okay, if it's changed, please call him. But if not, you're doing well. Someone with diabetes, with 45 years old and able to manage, they don't need. So the capacity is a huge answer of capacity in primary care is there.
And I think, too, aligning yourselves with the resources that are available in the community, right? You don't need to know everything. You just need to know someone who knows those things, right? So if you're, you shouldn't have to sit there and talk about fitness classes and why that's important, right, as a primary care physician. But having a partner and breaking down those silos to have it with, a seniors active living center, for example, they're the ones who are going to have that conversation. But being able to know that there's someone, whether it be your community support agency or whoever it is in your community, that then that referral can go there, that can take that off of your plate, but it's not, the patient isn't losing out on resources that they still need. But that's, community-based of what's available where.
Good.
All right. So thanks for illuminating panel. I want to direct a question to Kayla, but hope Mylaine and Liz could comment. So one of the things that came up in your comments were around immediacy, and that's not a term we use a lot. So I'm curious, to what extent is immediacy an expectation? So timeliness is like same day, next day, but immediacy is like 1 minute, 2 minutes. So what is it, like for the first time we have immediate services, Maple has a 2-minute wait time often. Health 811, chatbots, ChatGPT provide immediate services, or at least immediate information. Is that an expectation? Is that something we should focus on, or is it a distraction from, same day, next day?
Well, thank you for the difficult question at 3 o'clock in the afternoon on a Friday. I think immediacy is dictated by the patient, right? So immediacy is being able to get some sort of answer in some way, right? So it doesn't necessarily mean immediate, I want to see the doctor and I want to see them today, but immediacy is picking up the phone and someone is answering and they're having a solution. And that solution may be that it doesn't need to be seen in the next couple of days, but we have an appointment for a week for you. We'll talk to the doctor and make sure that they're ready, right? So immediacy is the change in that client's mind or the patient's mind to know that they're being taken care of. Yes, of course, then there's the immediacy to say, like, you need to call 911, right? There's that medical reason. But immediacy in the patient's view is about that they're being heard and that there is something to move forward with and that there's a next step as compared to not knowing what's going to happen in 5 minutes, not knowing what they're going to do in a week, not knowing how they're going to get their aging father to an appointment that they don't even know where it is. Those are things that we're in immediacy of saying, okay, there's an appointment scheduled this time. You can connect with, we're going to connect you with, again, I keep going to community support agencies because that's my wheelhouse. But, we're going to connect you there, and then that transportation is scheduled. That's immediacy. The appointment can be in a week. The appointment can be in a month based on when it needs to be. But knowing that and knowing that there are steps taken is what the patient's looking for in immediacy.
I guess I'd answer this 2 ways. So one, I really fully endorse what you've just said, Kayla. I think once everyone is attached to care and has a longitudinal relationship and the confidence and trust, then you have the conversation about what does it mean? What does convenient care mean to you? What do you need? And we know, I'll just speak for myself. I know some of my patients who what they need is a monthly call from the nurse to help them get through the next month and not feel they need something more immediate. That's answer one. So attachment to a trusted team, longitudinal relationship with an individual understanding of what immediacy means is part of it. The other part is, this is a new world, and even in that, we have to deal with what's going on with convenience, and I don't know the answer to that, and I think we need your help as researchers to figure that out, because it's like what happens when, and it relates a bit to the low-value care, it's like what happens with highways. It's congested, you build another highway, and then there's more cars, and then you have to build another highway. So I think we need to deeply understand where to meet our patients with this and with what. And the challenging part of this, and I'm, would look at you, would ask you the question back, of course, is what we think might be an answer with AI today. 6 months from now, it's a whole different technology. So as the government side, maybe I think I get advice on what I should implement, and then I try to procure something, and it's 2 years later, and that was not immediate and now totally out of date. So I think both things have to happen concurrently, and I really hope some of you are digging deep into that space of helping us understand truly what it is for patients to get that immediacy, and then what's the technological and operational options in our practices to achieve that.
Thank you. I just want to, do we have anyone monitoring for questions online? I just want to defer to see if there's anything there.
Not right now, Scott.
Okay. Please.
Thank you so much. Just by way of introduction, I'm Brienne. I'm with the Northern Ontario School of Medicine. Those of you that attended my talk, I talked about the chip on my shoulder, being from Northern Ontario and not necessarily feeling represented a lot. Lake Superior wasn't on one of those slides, so just calling that out. But also level setting. Thrilled to have a patient partner with a rural perspective. Love it, because I think those perspectives we don't necessarily hear. And so, long-winded way, how can we start to see some equity-centered measurement in access? Some of the indicators do not resonate with Northern Ontario. I spoke to why attachment doesn't work when we've been doing geographically based care for, decades possibly. So how can we start to unmask? Mylaine, I loved your slide that looked at access between attached and unattached. I copied that down. How can we look at equity-centered measurement so that we're actually making improvements in an equity-centered way? Thank you.
That's an important topic, and it's something that we are sensible, even in the caseload of a provider, how you manage that and how you use this information to respond to your patient. And when you look the attachment rate in Ontario, how do you take that in consideration when you attach a patient that comes from more area that is low income? So that is a great question, and it's really challenging to weigh that, but we have to think to give that in mind. In Quebec, for the family medicine group, when the patient is located in a région défavorisée, they give more weight in the attachment rate because the other provider is based on this number. But it's not money, but if you have, let's say, 10,000 patients enrolled to this practice and the patient come from région vulnerable patient, you're going to have more other provider in the calculation. So it's a way to start, but I think it's maybe something that the minister can have in mind in the attachment. What are the characteristics we're looking, because we know that sometimes it's taking more time and so on, and they need more resources. So it's something to keep in mind, and I invite you to have this reflection.
Yeah, thank you for raising. I mean, critical for us to do this correctly and consider equity in its many dimensions, whether we're talking about rural, remote versus urban, language. I mean, we think about accessibility and language and all those implications. So, yeah, I mean, I think part of it, and maybe I'll just reflect, like, I have not done the tour that some others have done all around Europe and other places to understand other jurisdictions versus our primary care. And mostly, they really get it right everywhere else, and we have a lot of things we need to do, which is where we're headed in Ontario. But one place when I went to Denmark that I thought was really interesting, where we are not where we maybe need to be on equity in terms of having the measures and the indicators, but I think where we are further ahead than other places, is in this consideration of the variation we have in our populations by geography, by equity, by different populations, our Indigenous population, again, different question about how do we, with humility and in alignment with their values and ways of healing and being, how do we, consider all of that? So I think it's part of the conversation. I can tell you it is, and some of it is just as simple as making sure when you're measuring the outcomes, you're stratifying by some with those considerations in mind. But yeah.
Anything to add, Kayla?
I mean, from the perspective, the rural communities face the different challenges than those in metropolitan areas. I've been at places before where people are like, well, just make sure they get a bus pass. Yeah, there's no bus, right? So understanding your own community, and I go back to what I mentioned before about being able to put in proposals to say this is what's going to work in our community is really beneficial, so that the experiences that your patients have and the challenges that you have are very different where you are, even as compared to someone who might be 100 kilometers down the road, right, in that community. So keeping that focus on what your patients need in your community and be able to kind of morph around the things that you have to do and the data you need to collect with that in mind is going to keep that patient focus first.
So we are down to our last few seconds, but I never want to turn anyone away from the microphone. So we have time for a brief question and some brief responses.
Thank you for the opportunity to speak. My name is Steven, and I'm a PhD student in Queensland University. Mine is not a question specifically. It's just thinking about all we've been discussing here today and trying to compare that with what is obtainable in United Kingdom, where I lived for 5 years. One conclusion I have in mind is there's no standardized care in Canada in terms of primary care. And what I mean by standardized care is, in the UK, if you go to the least place, I mean the underserved area in the UK, at least you will get like a primary care center. And in that primary care center, you have the team based there, regardless of the number of people living in that locality. So that is not available in Canada. So we need to get that right first. Then when we get that right first, we can improve on that, and we can individualize that to suit individual person. So if we keep going back and forth, not addressing that lack of standardized care that we don't have, we will be spending resources and be doing a lot of things and would not achieve the goal. So we can create one standardized care for Ontario specifically. Let there be availability of the basic resources in all of those localities. Then over time, we can improve that. We can do that to suit each individual demands in that locality. So that's what I have to say. Thank you very much.
Thank you.
Thank you so much for those comments, and that brings us to the end. I guess I naively thought that when we were done this conversation, we would have come down to 2 or 3 ways that we're all going to agree to measure access. But I think what we've heard is it's micro level, there's meso, there's macro, there's physician dashboards, there's making sure that it matters. What matters to the patient is captured in the metrics, and that actually one size isn't going to fit all, and it's actually going to be measuring access, for whatever the purpose is, the type of care that you're accessing, the reason you're accessing care, and that we'll have to live in a world where there's going to be multiple data sets, but with lots and lots of meaningful data that hopefully reflects we're providing better care for our patients. So thank you for joining us, and please stay for the next session as we transition.